Hi, and welcome to Hear the Rare Voices of the DIPG community. My name is Rachna Prasad. Welcome to episode 9 with Dr. Jessica Foster from Children's Hospital of Philadelphia. Dr. Foster's research and clinical interests lie in bringing immunotherapy to use in pediatric solid and brain tumors. During her pediatric oncology fellowship, she joined the laboratory of Dr. Adam Resnick, a leading expert in pediatric brain tumors, and Dr. John Maris, internationally renowned expert in neuroblastoma. In collaboration with Dr. David Barrett and Dr. Stefan Group, who have successfully translated chimeric antigen receptors, CARs, from bench to bedside for treatment of relapsed acute lymphoblastic leukemia, Dr. Foster's work focuses on developing CAR T cells for pediatric solid and brain tumors and improving CAR T cell efficiency and safety using RNA-based technologies. Without further ado, here is episode number 9 of Hear the Rare with Dr. Jessica Foster. So then to start, can you tell me about your path to becoming a doctor and then also specifically when you got introduced to a DIPG patient?
Sure. So I went to undergrad thinking I knew I wanted to do science and was between doing a MD or more research. And slowly while I was there, learned that you could actually do both. And I also started volunteering at a children's hospital and realized that I absolutely loved seeing patients. And so it was in undergrad that I decided I wanted to go to medical school and never looked back. And it was actually in undergrad as well that I had some experience in high school volunteering with pediatric patients with cancer. And so was already drawn to that sort of before I had even gone to undergrad. And so I kept going and never really looked back and never really wavered in my interest in pediatric oncology. I tried everything out, but at the end of the day, really that was where my heart was. When I was doing my undergrad, I also did research in a circadian rhythms lab. And so I majored in neuroscience and behavior and had a lot of neuroscience research and courses. So I was always very interested in the brain. And then after I had gone through all of my training and gotten into fellowship in pediatric oncology, I really knew that I wanted to become a pediatric neuro-oncology oncologist specifically. So that's sort of my path and how it came to be. And as far as the first DIPG patient I met, it was actually as a first-year fellow, so a pediatric oncology fellow. And I remember so vividly the conversation that we were called from radiology. There was an outpatient who was having a scan, and it was an unexpected finding. They had some subtle neurological signs, but nothing major. And so myself and the attending, we walked over to radiology and met with the family there in a room. And it was just, absolutely heartbreaking and heart-wrenching and something that you can never, ever forget. And I feel that way about every single patient I've ever met and taken care of, honestly. It is always a heart-wrenching and incredibly difficult diagnosis to discuss. One thing I particularly remember about that patient, though, the first one was, it was before the time when biopsies came back into vogue. It was sort of when there was a little bit more controversy about whether or not to do biopsies. And so that was also a very interesting part of the discussion, thinking about, do you biopsy? What do you gain from biopsy? Because at the time as well, it felt at least like the clinical trials were a little bit more limited in what we could offer. So it was interesting to think about it from that perspective as well.
Right.
And see how much the pendulum has swung from, no biopsies at all to now almost everybody gets a biopsy.
Yeah, I was just going to say that too. That it's almost, I guess people say it's almost standard of care now, right?
Right. Yeah.
Yeah, that's very interesting. Also, so I know we have never met before this, so I kind of was doing a little research on what your field of interest is and things like that. And I saw that you focus a lot on immunotherapy, right?
I do.
And then I just wanted to know what made you kind of specifically interested in that aspect of treatment, and then why do you think it's so important to study?
Yeah, it's a great question. So when I was finishing my residency and chief residency and applying for fellowship, it was right around the time when all of the news was occurring and the buzz from Emily Whitehead, who was the first CAR T-cell patient that was treated here at CHOP, that got a lot of press because it was a big success story. So it was right around then that I was applying, and reading about that and learning how they made the CAR T-cells and everything was very, very exciting for me.
Mm-hmm.
And so when I started to look for fellowship, I knew I wanted to go to a place that was strong in immunotherapy.
Mm-hmm.
It just seemed like such a neat, different way to attack cancer by using your own body's immune system to be able to fight it. And so that was what really interested me at first. And then when I got here and started fellowship, I was actually taking care of those CAR T-cell patients when I was taking care of the leukemia and lymphoma patients here at CHOP as a fellow. And it was amazing to me to see that success for those patients who were multiply relapsed and were considered incurable. And all of a sudden they were treated with this and now completely curable. And I said, wow, that's what I want to work on. And that's what I want to bring to patients who have brain tumors, because that is really, I think, the wave of the future. It's just a totally different way to go after this. So it was exciting for me. I got to see it firsthand, really from the beginning and still riding it. I think the wave is still going up as far as our knowledge and application. So it's a really exciting time, I think, to be both a physician and a researcher in the field.
Yeah, no, definitely. And then I guess going off of that too, can you maybe explain in I don't know, just like a colloquial way, I guess, like what CAR T-cell really is, and then maybe specifically about what you guys do at CHOP, because I know that like Stanford has some CAR T-cell stuff going on and Seattle does too. So maybe like, are they all different? Are they similar?
Yeah, great question. So CAR T-cells are basically, the way I like to put it is, so you're taking out the immune cells from a patient and you specifically filter them down so that way you get these one particular type called T cells. And you can do a variety of things to the T cells, but the point is, at the end of the day, what you do in the lab is you get these T cells to zone in on one target. So that way they become these almost like serial killers or assassins, where they go directly for this one target and that's all they do. And so by manipulating them in the lab, we can do that and then put them back into the patient where they go through the body and again, ideally go after that one target that's sitting on the DIPG. That's what we're all doing, and they've done it for leukemia and other types of tumors as well. But the work that I'm doing, and that, as you mentioned, the other folks are doing, Seattle and Stanford, is focused on trying to get it for DIPG. So the difference between the programs, there's a couple of different differences. The first is the targets. So what protein or sugar molecule on the surface of the DIPG cells are we going after? And so Stanford right now has an open trial where they're going after GD2, which is a disialloganglioside is the fancy name for it. It's a sugar molecule, like a sugar lipid molecule that sits on the surface. And actually that's the target that I have been working on a lot as well. But we do it through different ways. So that's part of the difference, is how we get the T cells to go after that target. They use a virus and I use mRNA to be able to get that T cell to go after the target. Seattle has a totally different target. They're going after B7H3, which is a different protein that's on the surface of DIPG cells. And the other thing that's a little bit different between the different places is how they're delivered. So Stanford has largely been doing these through an IV or through a central line. Myself and Seattle, we're very interested in doing local regional delivery. So putting it directly into the CSF or into the brain or the tumor itself to get them right where we want them. Because there is some concern that, them having to travel through the blood and get into the brain might be difficult. It's not impossible, but we think they work better when you put them directly into the brain or into the fluid around the brain.
Actually, I had a question about this, which I have asked multiple people, but no one has given me, like, can do T cells when you inject it, like through an IV, like do they cross the blood-brain barrier? Do they have to? How does that work?
Yeah. So they can. And we knew that actually from the leukemia data from the CAR T cells. They actually can have relapses in their spinal fluid and in their brain. They can get big clumps of tumor too. And when they gave the CAR T cells, you could see them. You pull off the CSF and you could actually see them there. So we know they get in. The problem is how many get in and how long they stay is I think a little bit unknown and also variable. Whereas if you deliver it directly into the brain, you know that you're setting a set number and you're giving it there. They also don't tend to stay there in the brain for a long time. There's something about the fluid or in the microenvironment there that's just not ideal. T cells prefer to be in blood. That's where they normally live. Yeah. And so they either get exhausted or they leave. And so it's a finite amount of time that you're going to have them active there, which gets to another point, which is some of the differences is, myself and others, we think that repetitive dosing is going to be important and sort of going after it multiple times, because we know that space, the T cells just, they don't hang around forever, unfortunately.
Interesting. No, it's a really interesting topic, I think, as well. And it's like not something I know a lot about. So it's really interesting to hear about. And then just another question off of this. Was it successful in leukemia because the target was really specific, or like what made that, like such a big success?
That's a great question too. So it was, I think, a stroke of a lot of luck on multiple fronts. So the first is that the target was CD19, which is expressed not only on the leukemia cells, but also on B cells. And so there was a lot of that target around. And so the T cells, even if they weren't touching leukemia cells, they were interacting with the B cells and making them grow and proliferate. So there was lots and lots of them. And so I think that was one piece. The second piece is that they were in the blood. When you're dealing with, they're sort of free floating. It's the easiest setup in the world. They can connect and interact, and there's no barriers. There's no big hunks of tumor or necrosis or issues of different microenvironments that you have to go through. It's all just in the blood. And so I think all of that together made it a really nice setup for success. That unfortunately, now that we're doing it in a different scenario, we're finding we've got these barriers we've got to overcome. But we're learning and we're getting there, and I think we're figuring out that it's not going to be quite as simple, but I think that we can still get there.
Yeah, no, that's very interesting. Cool. And then I guess it also goes off of what we've been talking about. Is there anything that's like up and coming that you're really excited about in research or in what you're doing, or anyone else, that you've heard of?
Yeah. I mean, I think there's so much exciting stuff going on. I think the intersection of genomics and immunotherapy is really, really neat and really exciting to me. And I think the idea of combining immunotherapy with targeted therapy that maybe can help drive the expression of the target, that is really, really exciting to me, and something that I know myself and others are really interested in sort of pooling our collective expertise, so I can bring the immunotherapy piece and hopefully pair up with others who have some of the genomic knowledge, and we can sort of put our brains together and figure out, okay, if we tweak X or Y in the cells, how can we make them more susceptible to be able to then attack them with the T cells. So so I think that's really exciting, and I do think that I have never felt more excited to be in such a collaborative environment, where I think people across the United States, but not only there, across the world, are really eager to put our minds together and hopefully solve this sooner rather than later.
Yeah, no, I definitely agree. And then last kind of just, I guess, different type of question is, what is the favorite part of your job? And is there a piece of advice you would have for someone that wants to pursue the same line of work?
They're great questions. Definitely my favorite part of my job is the patients, 100%. Always.
Yeah.
It's what motivates me to go back into lab after I'm on service for a week. I'm never more productive and never more excited to get back to the lab as after that week of service.
Mm-hmm.
And they're just awesome. I mean, the kids are amazing. They're fabulous and just incredibly, incredibly inspiring. So that is by far my favorite part of the job. As far as advice for someone who's looking to do this, oh my goodness. I think the best advice would be to not give up, to make sure there's definitely going to be bumps along the way. There's going to be setbacks. There's going to be research that doesn't work out. There's going to be, patients that unfortunately don't make it. But the most important thing, I think, is to still have hope and to still keep your eye on the prize and to continue and to keep going and to try again, no matter what. Every success was built on multiple failures before it. So don't let a setback set you back, because definitely, we learn from each iteration, each research project, each, patient, each trial, everything helps us get better and better every time. And so, keep it up, because we need it. We need more people to come into the field and bright minds to keep working on this and taking care of the patients.
Yeah, no, that's a really good piece of advice, I think. But yeah, that's all that I have. Thank you so much for answering all my questions and, explaining CAR T cells really well. I really feel like I got something out of this. So it was very nice.
Oh, great. Great to talk to you. Thanks for inviting me.
Thank you so much, Dr. Foster, for taking time out of your busy schedule to talk with me. I really enjoyed our conversation and found it very informative. As always, thank you to everyone who is listening. Your support means so much. The video for this episode can be found at heartherare.com, and the audio can be found on multiple podcasting websites. If you know anyone or you yourself would like to be part of Hear the Rare, please reach out through Instagram or Facebook, and you can also email us at heartherare@gmail.com. For today's gratitude, I would just like to say that I'm very thankful for this platform that is allowing me to meet and talk to new people. Dr. Foster was someone that I met through a previous guest, and I'm very grateful to have been able to talk to her and get to know her. Thank you so much to everyone who has supported me through this journey from the beginning and who has just joined. That's all from me for now. See you next time on Hear the Rare.